are looking for the erythropoiesis, note the quantity and quality of erythropoiesis, whether it is normal, reduced, or increased, and whether it is normoblastic or megaloblastic. And also look for dysplasia feature as well, like dysplasic feature, cytoplasmic bridging, nuclear lobulation, multinuclearity, and fragmentation, etc. etc. The other thing is myelopoiesis, and here you are also noting the quantity and quality of myelopoiesis. Particularly look for any change in maturation sequence, granularity of the cytoplasm, like it is hypogranular or it is hypergranular, excess of eosinophilic or basophilic cells. Like we have already discussed it, what is the normal value of eosinophil or basophil in the bone marrow, and presence of giant myelocytes and metamyelocytes. You are looking for the examining parasites, and examine for the presence of parasites, particularly Plasmodium falciparum. Like this is a bone marrow smear, and here you are looking that it's zoom. So this is Plasmodium falciparum, which tends to sequestrate in the bone marrow, and similarly you are looking for Leishmania donovani. So these are the parasites which are almost present in the bone marrow, and sometime we are dealing with other disease and we miss some such type of parasite. This also has some importance in the bone marrow examination. Now, what is a myelogram? And you know about the DLC, that is differential leukocyte count. So, what is DLC? You are looking 100 cells under the microscope for a peripheral smear. And what is myelogram? So, now you are looking or you are performing differential count of all nucleated cells in the bone marrow. This should include all stages of the maturation of WBCs. However, all stages of erythroblast are counted collectively. At least 500 cells should be counted. It is preferable that differential count should be performed for more than one random selected area. uh, the differential count of bone marrow smear is called myelogram, and the differential count of peripheral smear is called DLC, that is differential leukocyte count. That is counted in 100 cells, where myelogram are counted in 500 cells. These are its normal values, as we have earlier discussed in the earlier slides. So like myeloblast 0 to 3%, promyelocyte 3 to 12%, and then so on. So the other thing that you are looking for, that is ME ratio, and it also has very important in the examination of the bone marrow. And what is ME ratio? It is myeloid to erythroid ratio, or simply we say that it's the calculation of myeloid erythroid ratio. And how we are calculating this? So this is done by dividing the total number of myeloid by the total number of erythroid cells. And note that lymphocytes, plasma cells, and other non-myeloid and non-erythroid cells are not countable in this ME ratio. They are excluded. So calculate the myeloid erythroid ratio, and it's almost done by dividing the total number of myeloid cells by the total number of erythroid cells. This is a normal ME ratio, myeloid to erythroid ratio, and this is increased ME ratio. Myeloid to erythroid ratio is very highly increased here. Now, the next thing is you are looking for some sort of blasts, and we all knows that we have myeloblast and we have lymphoblast as well in the bone marrow. So if the bone marrow contain excess of blast that is more than 5%, then give their morphological description and their differentiation between myeloblast and lymphoblast. That you will write the morphological feature of myeloblast, you will write the morphological feature of lymphoblast. And if you are dealing with some lymphoblastic leukemia or some acute myeloid leukemia, then also they have very much importance, and their importance are then changed because uh, if you are looking more than 5%, then you are looking for more than 30% or more than 20%. Like in WHO classification, we need more than 20% of blast in a bone marrow or peripheral, and in FAB classification we need more than 30% of blast. So on that time you have very much importance of the blast in the bone marrow examination. Then, so some of the bone marrow need some special staining, like in iron deficiency anemia or some iron storage disease. We need iron or pearl stains. That is Persian blue stains, or also called Pern stain. So examine Persian blue stain smear first under low power for visible hemosiderin fragments, and slightly color or few granules are normally present. Note whether iron hemosiderin is increased or absent. Then examine under oil immersion for quantity and quality of hydrocytes as well. And hydrocytes are mature red blood cells containing few hemosiderins, where sideroblasts are erythroblasts containing hemosiderin granule in cytoplasm. Normally, in about 40% of polychromatic erythroblast, few small hydrocyte granules are seen scattered in the cytoplasm. Particularly look for the ring sideroblast at periphery of the fragments, and these erythroblasts in which hemosiderin granule are larger, more numerous, and arranged in the form of ring around the nucleus. These are only seen in disease stages of, that is sideroblastic anemia or myelodysplastic syndrome. So these are the special staining which are used in certain disease. And then we have cytochemistry. In cytochemistry, we are performing myeloperoxidase, non-specific esterases, acid phosphatase, and periodic acid Schiff base. So in case of leukemias, further cytochemical stains may be required to differentiate between various FAB types of leukemias. Like in acute myeloid leukemia, we are staining MPO or NSE. Then we looking for MPO, that whether it's stained or not stained. And we are also looking for acid phosphatase, periodic acid Schiff base in the lymphoblastic leukemias as well. So these are the special stains which we called cytochemistry. And here like myeloperoxidase, so it's detect myelocytic cells by staining cytoplasmic granules contents. It's mostly positive in acute myeloid leukemia. Then we have Sudan Black B, we call it SBB, and it detects the myelocytic cells by staining cytoplasmic granules contents. Then we have periodic acid Schiff, that is PAS, detects lymphocytic cells and certain abnormal erythrocytic cells by staining of cytoplasmic glycogen. Here we have esterases, and it's distinguished myelocytic from monocytic maturation stages. Several esterases substrates, and then we have tartrate resistant acid phosphatase. We call it TRAP, and it detects tartrate resistant acid phosphatase granules and hairy cell leukemias. So what are the importance of these special stands? Like iron stain, an identification of iron deficiency or iron overload, and the specimen needs for its fresh marrow spirit. Then cytochemical studies are usually used for diagnostic of leukemias and lymphoma, and the same fresh marrow is required for it. Cytogenetic studies, diagnostic of acute leukemia, like cytogenetics, like we are looking for deletions, translocation, polysomy, remission of studies, and 1 ml marrow and heparin is needed for these cytogenetic studies. Molecular studies, like PCR for diagnostic point of mutation, minimal residual disease studies, and it's also need 1 ml marrow and EDTA. Then we have fluorescent in situ hybridization, standing for diagnostic mutation, minimal residual disease studies, and it's also need fresh marrow spirates. This then the most important thing is flow cytometry, and its need for immunophenotyping, usually of malignant hematopoietic cells, clonality, minimal residual disease, and 1 ml marrow and heparin, ADTA, or acid citrate dextrose. So these are the importance of the bone marrow special staining, and you know that the bone marrow has very important role in the diagnostic of some disease which are unknown or which are yet not diagnosed. Now this is a laboratory bone marrow report, and here you are looking for its name, its room number, patient number, specimen number, then uh, put the date, its age, sex, and which race he or she belongs. It's a special type of bone marrow report, but sometime we exclude these race or room number or something. We are looking name, date, age, and sex, and patient number. Sometime we are also included address over here, attending physician, and who are the pathologists who are performing this test. Then here we have its pathological diagnosis, like in this case they have acute myelomonocytic leukemia, M4, and or if he has some clinical disease or some clinical history previously, so we mention it over here. Then on the other hand, we have myelogram. We also call it differential count. Uh, it's the count for peripheral blood, okay, and it's the count for bone marrow. So sometime we missed, or sometime it's unknown, or it's complicated to diagnose disease on the basis of peripheral blood smear. So then you are going to require the bone marrow spirates or bone marrow refined biopsy. So here this is bone marrow spirate, and you are looking for the hemogram, myelogram as well, like blast are 77%. So it's mean that blast are very high, and if you have more than 30% blasts in a bone marrow or peripheral, then you think about the leukemias. Here you have myelocytes, then segmented neutrophil, then you have WBC count, its count, platelets count, MPV, hemoglobin, and these are normal lymphocytes present in peripheral blood and marrow, and here is the normal percentage of the Marrow ranges, and this is the normal percentage of the Marrow range over here. So these are the myelogram or bone marrow report, which you are going to diagnose all these type of cells, and you are writing over here, and then you have finally a specific diagnosis.